So I think, okay, let's start. Shall we?
Yes, we can.
Okay. Rao, can you please turn on your camera so that you can see? And you can turn on your mic as well, because I think you're going to have a lot of talking. So today we are going to talk about asthma, which is very easy guidelines again, as you have seen. Did you manage to get to read the guidelines,
Yes, I did go through them.
Rao?
No.
Okay. No problem. We'll go through them together. So, okay, so tell me, what is asthma?
This is a hypersensitivity reaction leading to constriction of bronchioles.
So as we spoke last week about COPD, how is it different to COPD?
There is no emphysema in this, although there is hypersecretion with no emphysema.
So in COPD, you get a constant narrowing of the airways. But in asthma, you get intermittent. And it's usually come up with some sort of stimulus. For example, if it's an allergic, or if there is any stimulus that causes the intermittent episodes of bronchospasm and narrowing of the bronchioles. So in COPD, they have got the disease or inflammatory response, which made the airway narrow, as in a chronic form. So it's asthma. In asthma is like coming and going condition. Okay. So if usually you see mostly young people with asthma, because if the asthma is diagnosed in the early age and then at the age of later on, if they have constant episodes, then it turns into chronic problem, and then will turn into emphysema and then carries on with COPD and becomes like that. But if you see a patient who is like 30 or 40 years old, it would most likely be asthma rather than COPD. The COPD, you label them after the age of 45, 50. Okay. So if a 32-year-old gentleman comes with shortness of breath and chest tightness, then start your initial assessment. I think I'm trying to emphasize too much on ABCD approach, even on the scenarios on the group as well, so that you become into the habit of thinking in the same way. Like in the recent scenarios which I discussed, I know everybody jumps to the conclusion that this is this. But I understand, but we always have to go step by step. And if you develop this habit, it will always help you in your further career, in your further exams, in your daily life, when you see the patients, to think in a stepwise approach, to treat in a stepwise approach, and don't jump onto the conclusions. Okay, so we will always talk about starting from the initial management. What is the next step? What would be the next step? And then what would be the next? So this way, you will less likely to miss things and treat the patient according to the needs. Okay. So yes, if the 32-year-old man presents with dry cough, shortness of breath, and some chest tightness, then how are you going to approach?
Like
Rao?
always, ABC approach.
Always, yes.
Always, if he can speak, then airways intact, and then in breathing, we will do the chest examination. And it could be a first attack of asthma as such, so we'll do complete examination with air entries and shifting of trachea, whether it is there, and rhonchi, crepitations.
So what's the most common thing that you hear in auscultation or even
It is
without
rhonchi.
auscultation?
Without auscultation,
Wheeze.
wheeze is there, and on
Yes.
auscultation,
Yes.
rhonchi are there,
Yeah.
all over the chest.
Yeah.
And it can be a
So,
chest spasm could be there with decreased air entries all over the silent chest can be there.
And
So
it's mostly, is it the inspiratory V's or is it expiratory V's
expiratory
in asthma? Yes.
and there is prolonged
So you
expiration
will
as well.
hear, yeah.
Yes.
So when they take a deep breath and you listen to their chest, when they exhale, then you hear the kind of thing that makes you think that this is asthmatic breathing. So yes, so first of all, we will give them oxygen. As soon as you see, make them comfortable, make them sit in the right position where they are feeling more comfortable. And then assess their breathing rate, their work of breathing, their effort of breathing, how much they can speak in one sentence, are they struggling? So in history taking, there are a couple of important questions that you need to ask, which will tell you how bad their asthma is. I know that this can be the first presentation, but usually the asthmatic patients, they are aware of the asthma. So there are a couple of things that you ask from the patient, which will tell you how bad is the normal asthma. Can you tell me what these two important or 2 or 3 questions that will tell you that how aggressive you need to treat the patient?
How long has the condition been going on?
So
How
you
many
basically ask them.
how many
So you
attacks
ask
per
them,
week,
yes, yes.
and whether
So
wheeze
if
is
somebody
there?
is non-asthmatic, okay, if you ask the patient, have they ever been admitted to hospital with bad asthma? Okay. Have they been admitted to intensive care with asthma? So that will tell you that in the past, they might have had a bad asthma attack for which they had to get intubated or admitted to intensive care. So that tells you that this patient can become very serious. Because once you have this kind of episode, then you are more likely to have the similar episode again. So it's kind of an alarming thing for you. Then you ask them how often you get asthma attacks and when was your last asthma attack. So the frequency, the severity of their attacks. This is the important information which you can get from the history. Okay. So once you ask this, and the patient said, well, I've never been admitted. Normally I get short of breath and I take my puffer or inhaler a few times and it gets better. But this time it's not getting better. Then you are kind of at ease that you might be able to make this patient better soon. Okay.
Right.
So after your initial assessment, what are the differentials because we are now talking about asthma, so obviously we will just think about asthma, but what other things can they be? What other differentials would come into your mind that this can be this or that?
Differentials with a patient with wheeze and bronchi can be like in old age patient can be COPD or pneumonia. Communicable pneumonia can be there, and cardiac asthma is also differential.
Yeah, so all sorts of shortness of breath differentials should be in your mind, and then you
ILD.
slowly,
Yeah.
yes. So you slowly try and narrow your differentials down to things which is more likely. Okay, I think some people have joined now. Can they turn on their cameras? Can you turn on the cameras, Kanza or Seher? Okay, if not, then can you hear us? Just let us know. Okay, it's fine. Okay, that's good. Thank you very much. So we are talking about, hello, we are talking about asthma, and we have just started our initial assessment. I don't know whether Kanza can hear us or not. Can you hear us? Can you hear me?
Yeah.
Okay. We're talking about asthma, and we just started our initial assessment. on a patient who is 32 years old and come in with shortness of breath and dry cough, and you've got wheeze, and we've done the initial assessment ABC, started the oxygen. So I was talking about 2-3 important features that you need to ask from the history, which is when were they previously ill, how often they get asthma attack, whether they have been admitted in the past with bad asthma, or have they been admitted to ITU. Okay, so these kind of the parameters which might give you an idea that how unwell he can be, right? So I'm just going to, and then we talk about the differentials. Any differentials of shortness of breath can be included, including PE, COPD, chest infection, or anything. So the history, either it can be just a simple asthma attack, or it can be an infective symptoms. So you need to make sure that when did the symptoms start, whether there is any fever associated, or is the cough productive, because normally in asthma you have got a dry cough and patient tries to get breathless and dry cough, especially at night. Okay, so I am now going to share a screen. I wonder if you can all see. Can you see?
वो सामने करो जो बदियां बैठी हुई हैं ना, उनसे को बता दो.
Can you see the screen?
Yeah.
Okay. So the most important thing is that to establish what sort of asthma is it. Is it a moderate? Is it an acute severe asthma? If it's a life-threatening asthma, or it's near fatal. So if you look at the chart, which is just in front of you, moderate asthma, you will have normal symptoms of shortness of breath, but their peak flow is more than 50% of the normal. So do you know how to do the peak flow?
FPV1 over FVC ratio.
Yeah, but have you got the peak flow meter in your department?
No. I don't think we have.
No.
It's just a simple device which you blow into.
Yes. It's just a handy device. You blow into it, but I don't think we have it here in ED.
Okay. I think I will speak to Dr. Ashraf, because this is a very simple device with a mouthpiece of like cardboard, which you can change for every patient. But the actual device should not be that specific or like very expensive. So it's very important to have it, because this is your measure of how is your patient responding to the treatment.
Yeah.
If you do that and do it correctly before you start your treatment, and then you can measure it after you give the treatment, and that will tell you whether your patient is improving or not.
Yes.
So just like we spoke about lactate in sepsis, so when you start the treatment, you see the initial lactate, and then when you, after your hour of initial assessment, you reassess their lactate, and that's your parameter which is helpful to see the improvement of your patient, whether it's responding or not. A similar case is always check the peak flow before you start the treatment, and do it after some time to make sure that they are getting better. So moderate asthma, if somebody has got their normal peak flow, which I think they're unlikely to know if you don't have it in your department, and it's difficult to know whether patient would know their normal peak flow. But if it's around 400, 500, then more than 50%, if they are having a 300 or 375 or something like that, then they might be just a mild, moderate asthma. So rest of the parameters, if you just go through these quickly, I mean, I don't need to read all of that. I have sent you the guidelines already. So it's basically, the idea is to establish that which type of asthma attack they are having. Is it an acute attack? Is it severe? Is it life-threatening, or is it near fatal? So there are lots of features. So I think when you see the patient, you will already know that how unwell they are. Yes, the way they are breathing, what their saturations are, what their respiratory rate is, whether they look tired, whether they're using their the excessive muscles, how poor the effort is, because the breathing will go more shallow, can't take oxygen in, they get bluer, and in some cases they start to become hypotensive and blue and arrhythmic. So this is life-threatening in that case. But in normal, moderate to severe asthma, they are roughly about the same. And your first line management should be, Kanza?
Uh, oxygen
And
bronchodilators, beta agonists.
yeah, so you start them with nebulizers,
Yes, nebs.
right? So you give salbutamol and you give ipratropium, both 5 and 500 mics of nebulizers. So basically your aim is to open up their airways because they are already in having narrow airways. So bronchodilator therapy is the first line. And then you give them, what's the next thing that you need to give?
Steroids.
Yes. So you give them steroids. So back-to-back nebulizers and steroids. So this is your first line management of asthma. Okay. In a young, fit gentleman who is having mild to moderate asthma attack, what investigations would you like to do?
Chest X-ray.
Did you do chest X-ray in every case?
In COPD or no?
So
ABGs.
this patient is 32 years old. He had few hours history of shortness of breath and chest tightness, and his respiratory rate is 22. His SATs are 92 on air, and you have started the first set of nebulizer, and he's still the same. Would you do a chest X-ray?
I think we can start with ABGs first.
Okay, so you do the ABGs, and they are fine. I mean, he's not that hypoxic, and his PCO2 is normal, his pH is normal. Anything you want to rule out on chest X-ray? What young people can have, which can cause shortness of breath and hypoxia?
Pneumothorax.
Yes, so it's okay to do a chest X-ray because you don't want to continue treating your asthma if there is an underlying pneumothorax, because they are having airway problem and they can have pneumothorax, especially in young patients. And if there are some infective symptoms, then you want to rule out infection or pneumonia as well. So yes, you will do a chest X-ray. Would you do blood tests?
Yes,
Yes.
CBC.
In a young fit gentleman with mild to moderate asthma attack, would you do blood tests?
We can to rule out any infections if they're having symptoms like fever or some other chest symptoms.
Yes. So you can do bloods, but they're not always necessary because they're not going to change your management unless they have got fever or pneumonia. So in emergency department, we, some things that we normally do in every patient, but we have to think ourselves that why are we doing this investigation? We need to stop ourselves by doing unnecessary investigations as well. So any patient who comes, he should not be having blood test by default.
Okay.
Okay. So he's a young patient. He's have few hours history of shortness of breath. It's most likely asthma. His chest X-ray doesn't show any pneumonia or pneumothorax. I don't think that his blood test will make any difference in your treatment or his management. So I would not really do any blood tests on him. Would you? Okay. Yeah. It also depends if the patient is on your first treatment. If he starts to improve, then definitely not. Yeah. And if they are not improving after the second or third nebulizer, and then you are apprehending that they might end up staying in hospital, then yes, it's important to do the baseline bloods, because if they deteriorate further, or if they aspirate, or if they develop later on pneumonia, then you will have something to compare it to.
To compare to,
Okay,
yes.
so I would not really jump to do the blood test as first thing as soon as you start the treatment. Okay, so if they say that some people, when they say they have got chest pain as well, or with shortness of breath and dry cough, I think it's very easy to get detract. You know, some people try and move towards the ACS pathway when they say chest pain. It's very common to have chest tightness when they can't breathe. So don't be, too much worried about is this pain cardiac. So what happens? You get, defocused from your main goal towards the wrong way. Did you get me?
Yes.
So if you are treating somebody's asthma and they say my chest is tight as well, so it will be tight, it will be painful because they can't breathe. But if you start thinking that maybe he's got a heart pain and you start adding troponin in their blood test, it's a complete waste of resources, because you've chosen completely different pathway. Unless is somebody who is middle-aged, like 45, and they've got some sort of past medical history or family history of ischemic heart disease, and they have got some persistent chest pain, which is not even getting better after your initial management, and then you think that could it be cardiac. So it's very easy to get off track if you keep in these things in line. Okay, so treat the most important thing first, which you think is the problem. And if you are not winning, then think about the other things. But if it's clear-cut asthma story, clear-cut wheeze, shortness of breath, start with nebulizers and steroids. People do get better. Asthma is very easy to treat. They start getting better. Okay, and if you see no improvement, then yes, have a lateral thinking. Think about other causes. Think about infection. Think about pneumothorax. Think about ACS or other parameters. Okay.
Okay.
So as you said, you don't have peak flow, which is very important. But anyway, if you don't have it, then there's no point talking about it, because that would be your indicator whether you can send somebody home or not. So if you think that patient has improved, keep them for an hour or so without nebulizer and see if they're still better and they don't have the breathlessness anymore. Then you can discharge them. Not straight away after the nebulizer is finished and they feel better. You need to keep them for some time to make sure that they don't go back into bronchospasm or difficulty airway. So you keep them for an hour, and if they remain okay, then you can send them home with 3 days course of steroids. The steroids, what did you give? Zara, what would you give?
Can you hear me?
Sorry? Rao?
Prednisolone?
Yes. So prednisolone 30 to 40 milligrams depending upon the size of the patient. Okay.
15?
30.
30 milligram per day?
Per day.
30 milligrams once a day for 3 days.
Once a day. Okay.
If it's moderate.
If it's mild to moderate. Because you are sending patient home, aren't you? So 3 days worth of one stat dose of steroid would be enough.
Okay.
And then you give them the advice
Right.
that if they feel short of breath and if they return, then by all means come back. But you teach them how to take inhalers, make sure that they are taking inhalers in the right way. They're not using inhalers in the wrong way and not
Right.
taking enough breaths. So the technique is okay. So
Okay.
sometimes they say that they have been taking their inhalers, but they're still not getting better. but they're not actually using the right technique. So half of the inhaler go away, and then they say that I have taken 10 puffs, but it didn't help. So make sure, ask them to do the inhaler in front of you. And if they do it wrong, teach them that this is the right way to do it. So now is the case when they are not getting better. This one was the moderate to mild symptoms, which you initially treated with nebulizer and steroids, and they started to get better and they improved. They become asymptomatic, their SATs improved, and they look much more comfortable. You can send them home with steroid. Now is the second case when your treatment is going on, patient is not improving. So your aim at that time is to stop moving him going into life-threatening asthma.
Yeah.
That's why we treat them. We don't want them to go into worse situation. And if they're already worse, then we treat them more aggressively. So when you give them this initial nebulizer therapy, if they are into life-threatening or fatal one, what else can you add with nebulizer and steroid that can help to open up their bronchioles or airways?
There are other options like aminophylline, magnesium sulfate.
Magnesium. Before
Yeah.
you give aminophylline is magnesium. So magnesium is bronchodilator, and it is very, very good if you give it in severe asthma attack. So 1.2 to 2 grams of IV magnesium, it's going to help. Okay, and it
Slow
will show you the
in
effect quite soon.
infusion, slow IV.
So I think it goes in about 15-20 minutes. So this in a small drip. It's not like a big drip, it's a small bag which you start, and it goes into 15-20 minutes. So by the time you are giving the nebulizer, getting the chest x-ray done and all that, you can give 15-20 minutes magnesium as well. And that really is helpful. Okay, so let's share the screen again. So here it all says, first of all, the oxygen, then prednisolone 40 to 50 milligrams for at least 5 days or until recovery. That's a steroid therapy to send them home. I think 3 to 4 days is fine, depending on how severe they were. So we don't give nebulized magnesium. It's not recommended. So don't try that. It's always IV magnesium. Okay, some people try and give magnesium as a nebulizer. That is not, there is no evidence that it helps. So you consider giving single dose of IV magnesium if the patient is got life-threatening or less than his PF is less than 50% of his normal. And that gives a good bronchodilator effect. So magnesium sulfate infusion over 20 minutes should be used following consultation with the senior medical staff. So I think if you got a severe sick patient in front of you, which you have given 2 or 3 nebulizers and steroids, and if they are known to have severe asthma in the past and previous admissions to ITU or previous intubations, then you start treating them aggressively in the first place anyway. There's no harm giving IV magnesium in that patient who you worried about getting more worse quickly. You don't wait for them to get worse before you give them. Okay?
Okay.
Then you give ipratropium, which I have already said with the initial management in the nebulizer therapy. So if the patient starts to deteriorate, for example, if after an hour of your treatment, he's not getting better, and you repeat the blood gas, and it says that they have started to retain CO2 and they're getting more exhausted, they are getting cyanosed, they are hypoxic, they're confused now. So these are all bad signs.
Very bad.
That means that we are not winning here and we need to involve the intensive team sooner, because this patient will end up having intubation and then aminophylline, which is usually given in the first dose you can give in the emergency department, but the following dose should be in ITU. Okay.
Yeah.
So I think this is all about asthma. We're just trying to keep this session a bit small for half an hour. So that's why I'm just trying to finish everything in half an hour. If you have got questions, you come forward, but the main aim that we discussed here is recognizing what sort of asthma is it, how aggressively you need to treat it, and your apprehension about how patient is responding and whether they can go wrong in the further hour. So you need to think ahead, think forward. If your first therapy is not helping, that means you need to be a bit more aggressive in your investigation, in your treatment. Get a chest x-ray done quickly, try and rule out things quickly, get things out of the way like pneumothorax, pneumonia. If you see any pneumonia, if there is a fever, give them IV antibiotics. Okay, if they're already looking unwell, start with nebulizers, give magnesium, give steroids IV. Okay, and if you still think that this patient is already looking very unwell, you don't need to wait for them to arrest on you or have a respiratory arrest. So call the intensive team, because they might come up to the emergency department at the stage when they are peri-arrest already. That can be the case. So in that case, you will not go through all this first, second, third line of management. Maybe your first step would be intensive care call straight away. And in the meantime, you start nebulizer. I mean, if patient is not able to breathe properly, is your nebulizer going to help?
No, obviously not.
No. So although you start giving them as much as you can to buy time for the anesthetics to come, but you plan for the worst case scenario. If they are really looking poorly, then get the anesthetic team straight away, give them the shot of steroid, give them IV magnesium to help them to, IV magnesium obviously work in a different way, not through their breathing, but it will help to bronchodilate. And if they, in the meantime, they stop breathing, you can bag mask valve them. Okay, open up their airway, put airway device in to open up the airway, bag mask valve until they get intubated. But this is the very worst case scenario, and that this should never happen in the emergency department while you are there. So just be vigilant, just be apprehensive about the worsening patients and treat promptly. Okay.
Okay.
Any questions? I think this was easy.
Yeah. It was
Like
easy.
we had these COPD guidelines were very easy, and this asthma guidelines are quite straightforward. So any questions? If you have, just come forward. Any questions?
I had to ask about IV steroids. We usually give a shot of Solocortef in the ER. So when is the call to make for that?
I think we spoke about that in COPD patients. If your patient is already struggling to breathe, if they are on oxygen and you're giving them nebulizer, then by giving the oral steroids, you are interrupting your management, isn't it?
Yeah.
So
it basically has no effect on how efficient both of them are. We just have to decide the route depending on the patient's condition.
I think, yeah, they work in the same way. So either you give oral or IV. The effect is the same, but it's just the mode that you want to give it, which is more beneficial and which is more convenient for the patient. So you don't want to get the nebulizers away from the patient in 3 minutes to let them swallow, to let them drink water, where we have got the worry of aspiration because they're not able to breathe properly. If they are mildly short of breath, yes, they need nebulizer, but they're able to speak sentences but they've got wheeze, you can give them orally, because it takes time to grow up the medication to get the IV line and to give the drugs through the veins. So it's purely on your clinical judgment that how quick you want them to be. So if you have got IV line straight away, go for the IV. Don't interrupt the oxygen and whatever you're giving nebulizer through the nose, mouth, and it will interrupt your nebulizers if the patient is really, really sick. But if they are able to talk, if they are fine, and if they just need a nebulizer, you can give them orally.
Okay.
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 So initial assessment, ABCS assessment, give oxygen, give nebulizers, give steroids. If they are more sicker than the normal, more parameters, then give IV magnesium. Chest X-ray, make sure there's no infection, there is no pneumothorax. If they are mildly unwell, there is no need to do blood tests in young patients. If they get better, they go home. If you're anticipating that they're not getting better, they're going to get admitted, and you want to infection to rule out, then yes, do the blood test, including all the baselines. Blood gases, very important on arrival after your initial management. It will tell you your CO2 and ABG is better rather than a venous blood gas. If they are better, keep them for an hour or some time to make sure that they remain okay. Send them home with 3 to 5 days course of steroids. Give them good advice, good inhaler technique. If they are deteriorating, involve ITU soon and get them intubated. And then aminophylline at that stage, which can be given in the ITU later. So this is a brief summary. Okay.
Okay.
So I'll leave you with that. I think we did a short session. So I did not prepare any MCQs because then it's going to be like an hour session. So I was supposed to do a smaller one. So next time we will do something else. If you have got anything in mind that you want, just feel free to write in the group that what would you like to do. I will talk to Dr. Ashraf and see what the next topic would be.
I
Okay.
think we are getting too many patients with loose stools. We can do the acute gastroenteritis.
Okay.
Like